Hello, nau mai, hoki mai. Welcome back to the final day of the Financial Services Council 2020 Conference Generations. I'm sure you've had a relaxing break following the calming tones of Jace Te Patu. Jace has such a story and an incredible vision for New Zealand and our younger generation. Be sure to practice his mindfulness techniques and maybe even the odd yoga pose on a regular basis to improve your own well-being. I have the pleasure of opening the final sessions of the FSC's 2020 conference. There is a choice between the final Generations session, focusing in on being better guardians, the second FinTech session of the day, which changes the focus from wealth tech to insurtech, the last of 4 insurance breakouts, which features Dr. Rob Young, and the third investment panel, discussing human versus digital in the advice space. Thank you again to our sponsors, ANZ and Partners Life, for their support of these sundowner sessions. Once again, in all sessions, there is the opportunity for Q&A, so please take note and enjoy. Mā te wā.
Kia ora koutou katoa. I hope you are all doing well on the other side of the screen. My name is Rosalyn Lambert and I am part of the AIA team as well as a committee member for the FSC, and I have loved organising this fantastic conference with the team. I've also thoroughly enjoyed all of the sessions so far this week and can't quite believe that we're on to our final sundowner session. I have the great pleasure today of introducing you all to the incredible Dr. Rob Young. Dr. Rob is an Associate Professor of Medicine and Molecular Genetics at the University of Auckland, and he has been a medical advisor with the insurance industry for over 20 years. Dr. Rob has a PhD from Oxford University and is currently studying the genetic susceptibility of lung cancer to smoking-related lung disease. We'll come to some questions at the end, but in the meantime, Dr. Rob has a fantastic presentation for us all. So without further ado, I'll hand over to you, Dr. Rob.
Hi there. Good afternoon. My name's Dr. Rob Young. Thank you for joining me in this session this afternoon called Medical Innovations, Keeping Up with the Pace of Change. I work at the Auckland University as Associate Professor of Medicine and Molecular Genetics. I also work as a consultant physician at Auckland Hospital. And today I hope to share with you some of the recent innovations in medicine that I think have relevance to us going forward in both our lives and in the context of insurance and financial services. I'd like to start with this slide just again to reiterate that this is really about how I see changes coming through in the medical arena and how these may affect our lives, and in particular today focus on work that I've done and work of others in the area of cancer. So as I say, I have the benefit of both a research background and a clinical background, and am able to hopefully provide a digestible account of some of the great innovations occurring around the world and also in New Zealand. So this provides a summary then, a little bit about genetics and personalization of risk, something about information sharing, and this idea of blockchains and the electronic medical record. And then information analysis, artificial intelligence, machine learning, deep learning, and other related software and technical ways of improving medical information delivery. There is also information about screening and advances made in computer-assisted diagnosis, the use of virtual reality, and more recently, very exciting advances in immunotherapy in the treatment of cancer. And lastly, a little bit of information about 3D printing and the development of artificial organs. Now, as I said, I'd like to focus a little bit on lung cancer because it provides a really good example of where these innovations are occurring, how they're occurring, the pace that they're occurring, and how they may affect a patient who has lung cancer. That said, a lot of what I'm going to say relates to other cancers and indeed other illnesses. And in each of these specific areas, I hope to cover off these various topics, and then in the end, touch on medical innovations and insurance cover. Let's just start then with genetics and risk assessment. So something I learned about that I wasn't familiar with before was blockchain. And those of you who are into bit currency may be well aware of this approach, a ledger of records, and in the context of medicine offers huge power in the individual, but giving and providing much in the way of security by bringing together a variety of sources of medical information that may come from the GP, from hospital, pharmacy, physio, and other healthcare providers. It allows the storage of discrete bits of information. It allows this information to be interrogated by authorized users. There's a degree of patient control. You see here the patient looking at their various sources of information, and it allows access by different specialists following approval, and so better communication between, for example, GPs and insurance providers, between GPs and specialists, between GPs in the hospital setting. And it's immutable and encrypted data. So blockchain then represents a development whereby information can be transferred, shared, protected on an individual, and improve discussion and service provision around that. Now, a follow-on to that is this new area of artificial intelligence. And you can see in this pictorial, artificial intelligence encompasses this wider idea of methods that allow algorithms to mimic human intelligence, to solve problems, to combine data, and to come up with information, risk, or diagnosis based on that information. And that this goes another layer with machine learning, which is to use statistical methods to improve the performance of this information. And then even further to deep learning, where this information is combined with new information and allows even greater understanding in a lifetime way. Now, in the context of genetics, this is hugely important because the Human Genome Project is providing us data in excess of billions of genetic data points that can be assessed in each one of us as individuals, so that our genetic code can be stored and then analyzed. At the moment, 99% or more of that code is not well understood, but this will be improved, I believe, as we develop more and more studies looking at the outcomes from specific genetic data in clinical and large randomized trials. So the opportunity then is to amalgamate your genetic code to make predictions about future risk. They may be relating to lifestyle choices and disease outcomes. They may relate to how well you respond to certain drugs. They may have any number of other clinical relevance that can be captured and then analyzed in these various machine learning approaches to provide really doctors and patients themselves with much more information from their human genome. Now, this slide shows all the different areas where artificial intelligence may, in fact, improve the delivery of healthcare. And this is applications such as interpreting imaging scans, CT or MRI scans, so you get a more accurate result than provided by a radiologist. Recommending diagnostic or treatment pathways, so this is functioning, if you like, almost as a doctor in itself, or an advice for a doctor. Risk assessment by collating genetic information, the utility of wearable devices, and then data and electronic medical records, providing composite scores or predictions about people's health or current physiological state. We also have the utility of virtual reality, in this case the virtual health assistant, and you'll see this already in customer service bots when you go and look at various sites and you have questions. In New Zealand, I think, electricity companies, you'll see these little characters on the side there. You can ask a question and answers are provided. There's also the prioritization of patients for particular tests, and in the public health system, this has important utility in terms of prioritizing people for investigations. In the area of pharmacy and drug delivery, already there are systems in the hospital that are available that look at a person's drug history, they look at the medications they are on, and they're able to identify where drug interactions may occur. This type of technology has already been used in so-called robotic-assisted surgery, and this helps the surgeon identify areas that are anatomically complicated and prevent complications. And there's also just an interesting prospect of biofeedback to patients about their heart rate, their blood pressure, their temperature, how well their lungs are working, and so on. So let me just come back then to genetics and lung cancer, and just say that recently in the Journal of American Medical Association, there was an article dedicated to polygenic risk scores. And these scores are essentially a composite of your risk for various cancers. And my group at Auckland University have developed one of the earliest scores in lung cancer. This is important because there is a growing number of genetic tests becoming available direct to consumers, as well as in the context of the medical world, because these tests are being rapidly developed and are going out into the clinic, and they provide people with an enormous amount of choice and opportunity to find out more about their genome and what that genome means to them. Here are some publications with regard to a polygenic risk score that has relevance to prostate cancer, to breast cancer, and to Alzheimer's. But there are several other applications where your genetic makeup is scored, providing you with some estimate of risk in the future. So where does this come from? Well, it comes from advances in about 2000 when the human genome was coded. Then we realized that there was huge variation between individuals, and that a lot of that variation came down to very discrete changes in the genes that encode various proteins and aspects of our health. So there are 3 billion base codes. These are spread across 23 pairs of chromosomes. And within there's around 5 million SNPs. And a SNP is a single nucleotide polymorphism. And this is shown here as a single change in this person's DNA code from an A to a G. Now, the vast majority of these changes, over 95% of them, are of no consequence. But some of these changes have enormous consequences, and there are a number of diseases we know of today that occur and affect individuals' lives that are based on a single base pair change, shown here. So how have we done this, and what do we do? Well, already there have been a number of very, very large studies around the world involving tens of thousands of people with a particular disease, perhaps lung cancer, and then others who are disease-free that act as controls, and the capacity then to take their DNA and look at various genetic markers that span the 23 chromosomes. And where you see these little blips, these describe or identify more often a particular SNPs found in a case group and indicating their relevance in the disease of interest. And it is through this statistical and very clever technological change that the genome can be examined in any one individual, identifying these disease susceptibilities spread across the human genome. And this has been done, as I say, for various cancers, coronary artery disease or heart attacks, and Alzheimer's, and indeed lung cancer. Now, these tests can be done on very simple samples, and indeed the tests we've developed for lung cancer can be done on a simple cheek swab where an individual just brushes the inside of their mouth. This little cotton device or plastic device, is a little brush, can go into a plastic tubing and can be mailed around the world, and that DNA analyzed in a lab 1, 2, or 3 weeks later, and genetic code tested for disease susceptibility. This is a big advance on the traditional blood taking that we have used in the past. Other approaches include spit testing, where similarly the cells inside the mouth end up in this little plastic receptacle and are then processed and the DNA extracted using forensic techniques. And indeed, genetic testing is being done on the traditional Guthrie card shown here, which is a heel prick test on a baby soon after birth, and a blood spot is taken, and that can be analyzed again for a genetic code. So our interest in lung cancer has been who of the smokers are at risk, because indeed only a minority of smokers develop lung cancers, and most smokers smoke on the belief that they won't be unlucky. They will not get lung cancer. They will avoid any complications of smoking. And while many of them will be correct, many of them won't, and these people end up dying prematurely from smoking. And for them, it's the double whammy of smoking and being genetically susceptible that has put them in that unfortunate circumstance. So we were interested in finding a genetic score that would predict not only getting lung cancer, but dying of lung cancer. And then ultimately in our most recent work, looking at how this score can estimate if screening for lung cancer is beneficial for that person. So in a study we recently completed in the US, we took a subsample of a study of 50,000 people who underwent lung cancer screening. These were older, higher risk smokers, and 10,000 of that group agreed to provide blood samples for DNA analysis. We were the first group in the world to analyze the whole 10,000 for various gene markers that we knew were related to lung cancer. And using that, we were able to validate previous genetic markers we had shown in New Zealand groups or cohorts. And one of the offshoots of this work was indeed that not only were there genes underlying lung cancer, some of these genes overlapped with those related to what we call chronic obstructive pulmonary disease or emphysema, another complication of smoking. That indeed one of the key genes in this overlap was related to the nicotine receptor. And indeed, this receptor is found in the lungs. So when you breathe in smoke, you also breathe in nicotine, and that nicotine binds to these receptors in the lining of the lung and creates an area of inflammation, a bit like a low-grade infection. And we believe this is very important and may relate directly to the ultimate development of lung cancer. Now, these little receptors are also found in the brain and thought to be central to the addiction that can go with nicotine. So if the gene that codes this receptor varies or is somehow functioning differently, it will mean that your level of addiction to nicotine and your likelihood of lung cancer are somehow linked and then part genetically related. And indeed, this is what we were able to show. In studies where we published as far back as 2008, and we're writing up work currently, we show that this nicotine receptor gene is indeed related to both developing emphysema, smoking addiction, and also developing lung cancer. And subsequent studies have supported this view. And what's really interesting about this as a side issue is that inhaling nicotine itself may be hazardous. And of course, in the current climate of unregulated vaping, this really indicates considerable concern about young people taking up vaping and in doing so becoming addicted to nicotine and also potentially setting themselves up later in life for lung disease and or lung cancer. Now, coming back to the utility of this test. Well, we know that the test not only predicts you getting lung cancer, it also predicts how likely you are to die of the lung cancer. And in the context of screening, this is critical. And this then became our interest in this cohort of 10,000 people I described, where we were able to look at their gene profile and ask the question, how do their genes contribute to their risk? And in asking that question, more importantly, how useful or how beneficial is screening for them? And what we were able to show was that people who had scores that sat in this region here, these are low scores, this is a very high score, those of intermediate score gained by far and away the greatest benefit. So if you were to take somebody at the beginning of a screening test or at the beginning of a screening program, and you decided to pick everybody of a certain age and pack years, you would have a large group of high-risk people. If you apply then this personalized information, you're able to be far more precise about who you screen, and thereby making this a much more cost-effective process in reducing death from lung cancer. So this is just one application of how you might use this technology. And so when you take this test, you receive a result like this, and it shows where you fall in this moderate, high, or very high risk spectrum. And indeed, not only your risk of developing lung cancer shown here is where and how beneficial screening might be for you to reduce any chance of dying of lung cancer. Let's talk a little bit then about the follow-on steps to this, which is diagnosing through imaging, and CT is one way this is done. So if you look at this slide here, you see two CT scans of different individuals. On the left here, this is a slice, like a bread slice through someone's chest. They're lying on their back, and here is their spine, here is their heart. Here is their lung cancer, conveniently pointed out with a little arrow, and here is their damaged lung, their emphysema. Here is their packet of cigarettes, unopened 20 cigarette pack, and this is primarily the driver of both this and this. Now, diagnosing lung cancer in a scan where this is what you see on the scan is a lot easier. When you're screening, you might see a scan more like this scan, where there's lots of little dots, and you can see this dot, this dot here with the arrow being the biggest of all of those. But that dot may not be cancer. This dot over here could be the cancer. And so distinguishing which of these many dots are going to turn into cancer or not is a significant issue. And for radiologists, may require and indeed can be improved by technologies such as computer-assisted diagnosis. And this is where artificial intelligence and machine learning may make considerable gains in allowing scanning to be done en masse and the interpretation of those scans to be made rapidly, so that this individual here can be told reliably that they do or do not have cancer, and that their scan should be 3 months, 6 months, or 1 year away. This type of approach is being applied to other forms of cancer, such as breast cancer, where mammography is being examined using computer-assisted types of software. So you see here in this image, the doctor is applying image analysis from their scan result using their own experience and also that of the artificial intelligence in order to process these scans and particularly abnormal nodules to decide on what is the next step to predict which spot on that scan may be problematic. And this, as I say, will extend into many areas of imaging in medicine. If we look then at something equally exciting, and that is immunotherapy and prevention. And this was a study that I was very interested in and published some related work on. And what do I mean? Well, in this publication here, what we show is your lungs are affected by environmental factors, air pollutant exposure, and particularly smoking. But according to your genetic susceptibility or resistance, you may go on to be okay or to have inflamed lungs, and with DNA damage get lung cancer or indeed emphysema. And it is this complex relationship that we need to understand at a biochemical and immunological level. Now, here is shown a number of what we call cytokines or inflammatory proteins that our body makes in response to infection, in response to cancer, and in response to obesity. And these and other factors increase the body's driver of inflammation. And I want just to highlight interleukin-1 beta, IL-1 beta. And that turns out to be very, very important in this story. Because about 2 years ago, a study was published where they looked at this drug, and this is the drug here. It's a monoclonal antibody, which means it affects your immune system. The drug is called canakinumab, and it was being used in a study for heart disease. However, they were interested in its wider effects, and so there was a secondary analysis where they looked at the outcomes of cancer. And what this antibody drug does is when you inject it into somebody, it's injected into the muscle and then absorbed. What it does is it affects the relationship of your immune cells. And shown here is a T cell, which is a type of immune cell that everybody has. And this type of immune cell, the T cell, is one of the cells we have that fights cancer. So what a cancer cell does is it has a number of receptors on it that deactivates the immune system. And so one way to prevent that is to give these antibodies and prevent the cancer's way of hiding in the body and allowing the body then to destroy the cancer. So the results of this study were extraordinary, and I think they were unanticipated. But just to give you a sense for this, it was a randomized trial, which means you have a placebo group that get just a non-active medication, and then the active group here, which was the group that got the IL-1 beta blocker, they're in red, and the control groups are in blue. And what you see over the course of this study, in which there was about 6,000 people followed for about 4 years, is at the end of 4 years, the lung cancer incidence, which means how many people got lung cancer, was a lot less in the people that got the active drug. And in fact, total cancer mortality was reduced in the group that got the drug. And that was primarily because lung cancer is one of the biggest cancer killers that we have. It accounts for more cancers than prostate, breast, colon, and uterus combined. And so lung cancer incidence and therefore lung cancer deaths were being blocked by this drug, which is an extraordinary outcome to think one drug can reduce the leading cause of cancer death in the world. So further studies, of course, are being done to validate and confirm this finding in order to see if this has the potential for preventing a lot of lung cancer. And you must remember that about half of all lung cancers occur in people that have already quit smoking. They have done what they can, but nonetheless, the risk is persisting. So this could affect a lot of people around the world if this is shown to be the case. And indeed, similar approaches may prevent or delay the onset of colon cancer, breast cancer, other common cancers. So a very interesting and exciting development. Now, if we look then at the immunotherapy in the context of current treatments, we will have heard already in the news about drugs like Keytruda, which is an immune therapy for melanoma, but it has interest in other forms of cancer. And this is another huge medical innovation using immunotherapy to treat cancer. So what happens here is when a cancer cell develops in the body, and in this case, let's say it's the lung, your immune T cell identifies this tumor cell or cancer as being foreign and attaches to it in order then to try and destroy it. Now, many cancers have also got receptors of their own that can block this relationship and prevent the activity of the T cell, inactivating it through this mechanism here. So the T cell attaches to the cancer cell basically puts up a block and attaches through another receptor to that cell and shuts it down. And this causes an inactivation and allows the cancer cell then to grow. This type of activity is called the checkpoint or checkpoint inhibitors, of which Keytruda is one example. And you can see that if you can block this activity of the cancer cell, then you allow the natural immunity of the body to destroy the cancer. And this is a massive development in cancer chemotherapy. So we know, for example, that it's relevant in melanoma, but it is also being used in New Zealand for certain types of lung cancer, and indeed around the world in kidney cancer, bladder cancer, and Hodgkin's lymphoma, a type of lymph gland cancer. And Keytruda and Opdivo are two types of checkpoint inhibitors. Let me talk then a little bit about artificial lungs and lung modeling. So in this pictorial here, you see a couple of things. On the left, here is a man who has an artificial lung. What this has to do is that this system taps into his blood supply and provides a system of oxygenation, almost like a little aqualung, where the blood is then oxygenated in the system and pumped back into the body. And it allows the heart then to pump that oxygenated blood around the rest of the body. Now, we already have artificial hearts operating exactly like this, where people literally carry them around, battery powered, and it basically provides an assist to a heart that is not pumping well. The technology is now being extended to generating lungs that could do the same. And here you see the oxygen bottle that's required to provide oxygen, to this portable artificial lung system. And in the slide on the right, you can see the development. And what you can't see is this little system here shows that blood coming into this little chamber. This represents a little air sac, and the air comes in and out of this sac, and the blood sits around that air sac and allows exchange of oxygen to go in and carbon dioxide to come out. This single sac shown here is the size of a 1-cent coin. So expanded up, this could provide the type of technology that would be, through nanotechnology, allow someone to have a portable lung or ventilatory system to be carried around with them. Now, 3D printing is also relevant and also plays a role in this process. In that 3D printing allows several advancements. One of them in not only producing these types of micro organs that can be scaled up for eventually organ transplantation, but 3D printing provides technology allowing for more accurate surgical tools to be synthesized, manufactured, the manufacture of organs that could then be used for surgeons to practice their skills on. And so really 3D printing is also making its way into the medical arena as a significant innovation in advancing various aspects of medical and health care. Here you see then some complicated lung modeling. This is the lungs sitting in the upper chest. The diaphragms are sitting underneath the lungs and they provide a billow. Here is a wee lung cancer. What is now occurring is that these cancers can be accessed through a bronchoscope or tube that's passed into the person's lung and can biopsy this cancer. The tissue from that cancer, from that individual, can then go into a laboratory-based system that can then be put into small cassettes that can be analyzed for things such as the genetics and the response to treatment. So you imagine then that in an environment of a laboratory, you can sample somebody's lung tissue and then really find out what treatment is ideal for them. Whereas currently we give people treatment and wait to see if it will respond, they will respond. This can be circumvented with this type of modeling system in the laboratory, providing a much more personalized and effective form of chemotherapy. Now, let me just talk a little bit about medical innovations in the context of insurance. There are a number of areas where I see these innovations taking importance. And already, as a medical advisor to 2 insurance companies, I'm asked to analyze and to interpret genetic information. We have a lot of BRCA testing going on for breast cancer amongst the insured population. We have testing for colorectal cancer through genetic testing. And as I showed you at the very beginning of this talk, there is going to be an avalanche of genetic tests that people can take either through their conventional healthcare or even directly online that may have relevance to their health profile and therefore how they might be viewed from an underwriting perspective. And remember that genetic testing can be good and bad, in that somebody who has a family history suggesting a great deal of risk can be genetically tested, and that family history can be seen as negative for that individual. And so, in fact, they can receive standard terms because their genetic testing is negative. There is a lot of genetic testing going on with cancer tissue, much as I showed you in that previous slide, where the analysis is showing which genes are driving which cancers, and with that, which genes are indicating what treatments may be beneficial. Now that's important because depending on the type of cancer you have and the genes in that cancer has importance to your treatment modalities, has a relevance to your prognosis. And these are all important when looking at insurance cover. Indeed, there has been suggested, not by me but by others, that amongst the smoking community, there are probably up to 30% of smokers who have a normal lifespan and a health profile much the same as a lifelong non-smoker. And this is an interesting prospect. Whether this provides a preferred kind of smoker's life option in life insurance remains to be seen. But as I say, genetics can tell you what you're less likely to get as well as what you're more likely to get. From a perspective of underwriting, again, early identification of pre-symptomatic disease. And this is actually a very complicated area in provision of financial services by way of insurance. And what I'm talking about here is people that carry certain genetic mutations but are perfectly healthy, both in terms of their blood tests, both in terms of their no symptoms, and if you scan them with a CT scan, everything would look entirely normal. And the question is, what does that mean? And that remains a challenge in interpreting that information and placing the correct risk around that individual. But nonetheless, this is what we have to face, and we will rely on large studies to provide good information with which to use this genetic information in a reasonable and fair manner. Claims, I already see the effect of some of these innovations, and I'll touch briefly on something that is again an extraordinary innovation in medicine, which is that of a liquid biopsy. And this is the capacity to diagnose cancer potentially even before it can be seen on a scan, and weeks and maybe months before anybody develops any symptoms. You can already see that in the context of terminal illness and predicting outcomes from cancers, personalized medicine really throws a spanner in this. It makes that process more complicated. Already, there are a number of diseases that are being redefined around their genetic basis, and diabetes is one example of that, where there are some people where we can define their diabetes as being wholly related to their genetic code. If I touch a little bit then on this liquid biopsy idea, this in this case again using lung cancer as an example, but really many other cancers, there is already advances being made in this process. Essentially, you take a blood sample, as I showed you before, and just a routine blood test. And because of the sensitivity of these assays or tests, you can detect within someone's bloodstream DNA that is not theirs, DNA that has originated from cancers. And in the course of that cancer developing and spreading locally, has resulted in DNA leaking into their blood system or blood circulation and being detectable on a routine blood test. Now, this is extraordinarily complicated because we don't know what the significance of that might be. For example, we believe that there is cancers that are in their smallest stages that people are indeed, and their immune system are indeed clearing. So that even a very small cancer where DNA may leak into and be identified in the bloodstream may not ever become clinically relevant in that individual. So I think there's an awful lot yet to be understood with regard to these liquid biopsies and the capacity to identify foreign DNA from cancers somewhere in the body that it ultimately requires some form of scan to identify just where that may be. When we come to things like the definition of cancer and trauma, liquid biopsies again are complicated in that we do not know whether this really clearly identifies a cancer as being invasive in the traditional pathological sense. That invasiveness is something that we judge based on microscopic analysis of tissue from biopsy. Dealing with bits of DNA identified in the bloodstream is a far more complex situation, yet to be better defined, better described, and understood in the medical context. So just to really recap on some of the things I've talked about today, there's an awful lot going on in both the analysis of information, both clinical information, genetic information, of interpreting that information using complex computer software, and also the storage of that information and the access to that information, such that these processes can be applied and much more understood from genetic data. Massive advances are being made in radiology and imaging. We already have the capacity to do full body scanning. CT screening now for lung cancer is fully recommended and funded in the US. It is also being taken up in the health systems in Europe. I'm involved in a group in New Zealand looking at CT screening for lung cancer in some pilot studies. But it's a very, very new area and certainly will be assisted by advanced diagnostic techniques through software. Described also the prospect of immunotherapy potentially preventing cancers, if not preventing them, certainly treating them or helping the body eradicate cancers that have developed, and a whole new area of therapeutics or treatments that we really didn't have 4 or 5 years ago. Imaging, 3D imaging, modeling are also making huge inroads in better understanding cancers, understanding disease, and allowing us to be better at treating them. And as I say, these things, as they become more and more involved in our medical context, will have a bearing on our insurance. So thank you very much. Happy to have some questions, Ros.
Great, thank you, Dr. Rob. I hope you can hear me now. Always a funny environment, and we've had so much practice with having meetings on Zoom, so I do apologise about that. But yes, we've got a few questions that have popped on in. So this first one here, thinking back to the piece you were talking around genetics. So with SNPs, do you know if anyone has done this longitudinally? For example, if one of the control group may later develop the cancer marking the interest group, could this be a predictive marker?
Yes, that's a very good question. And those studies have been done, and indeed we are currently publishing a study where the DNA was collected at the beginning of the study, and these people were followed for 6 years, and a subgroup of them developed lung cancer. And indeed, the markers we've identified do associate with that risk. And we're about to start another study in the UK, which will involve following around 300,000 people, again looking for markers for lung cancer. And indeed, many others around the world are looking at this data set for cancers, heart disease, neurodegenerative diseases, dementia, Parkinson's, all sorts of things. So this is really upon us, and we will be analysing data from this 300,000 cohort in the next few months to see whether our markers or how accurate our markers are in the context of lung cancer. So that is already happening.
Brilliant, thank you. Another one there around the genetic testing. Speaking of it being a double-edged sword, so insurance is a pooling risk with genetic testing, and we risk atomising and proliferating pools. So some pools might be such a high risk that they're uninsurable. So what would you think is the ethical approach for insurers to take here?
Okay, well look, I think insurers already put people in risk pools, and really lower risk people to a degree subsidize higher risk people. One of the difficulties with genetics is discrimination, and so my message there is that people should take up insurance and then get genetic testing, not the other way around, and that really makes the playing field level for the insurer and also for the individual. But if you imagine you're an ex-smoker and then you've got your life insurance and your trauma insurance coverage in place, and then you took out this genetic test, and I was able to say to you, you're at high risk of lung cancer, your insurance is already in place, and your risk is being subsidized by those in your pool that are of lower risk. You can then undertake preventive treatment. You could then undertake aggressive screening, this is in the future, and in doing so, reduce your risk of dying of lung cancer. And yet you still have that insurance cover should that occur. So I think there will always be, and should always be, the capacity for lower risk people to subsidize to a degree higher risk. It's finding that sweet spot where it's both fair and equitable, and that most importantly, people at risk can potentially change their outcome through modern medical technology.
Indeed. We've got one final question here. So, Dr. Rob, how important do you think it is for insurers to be working closely with DHBs to improve patient outcomes?
Yeah, look, a lot of people should be working close to DHBs to improving outcomes, not just insurers. I think the issue for DHBs is one of reactivity, unfortunately. Very little is done in the provision of acute medical care towards prevention. And in a way, insurance and the provision of insurance cover is an opportunity to engage people in their own risk. This has been done really successfully by the cardiovascular world in assessing people's blood pressure, age, smoking, diabetes, and saying you should do this or take this medication, this will reduce your risk, and so on. But we really haven't extended that beyond the cardiovascular model, when really there is, as I say, in the context of lung disease, smoking, lifestyle choices, all sorts of things that could be done there. In terms of the direct relationship, though, between insurance and the DHBs, I think that will be a difficult one in the sense that the DHBs, as I say, are chronically underfunded and managing existing healthcare needs. Insurance is providing, financial cover for people that get unlucky, and so while there could be provision of sharing of information, I'm not sure whether the DHBs really have the technical capacity to do that.
Sure. Well, thank you very much for your time, Dr. Rob. It's been a really, really interesting session. We do appreciate it. And thank you also to all of our wonderful viewers. Hope you all have a great evening.
Thank you very much. Thank you for listening.
Wow, what a range of insightful discussions there have been. I'm sure you had some difficulty choosing which session to attend, but then again, that's what's great about digital. They're all recorded and available to watch on demand at your leisure. There's no fear of missing out here. And so I guess that this brings the FSC conference to a final close. In a year full of uncertainty, adaptation, resilience, and agility, I think I can speak on behalf of the audience and say what a fabulous 3 days it has been. You have been an engaged, enthusiastic, and totally delightful audience, and we are very thankful that you have been here with us. I'm Yvonne Davey, Manager, Super and Savings, Craig's Investment Partners, and I have been your MC for day 3. I've thoroughly enjoyed sharing the show with you today. Thank you to the team here in the studio, and have a good night. E noho rā.